So I think that, can someone tell me that what are the two things because of which you have been able to reach to this stage? All of us are doctors, we are contributing, helping the society at large. But can you think something which happened which make you to reach to this level? I want it to be more interactive so that, see, evidence is something which keeps on changing, but the philosophy remains. And once we have the base, that philosophical base, irrespective of whatever the evidence comes, we try to understand that what is the right balance. You must have heard when Dr. Umesh Yadav was saying that there is evidence for use of insulin, but then we are not using it. So evidence is something which keeps on coming, it keeps on tweaking, but then I think the base is always is that the broad philosophy on which we work. And to me, it looks like that probably all of us must have established our breathing at the time of birth. That must have been the most crucial step. And second, another crucial step which must have happened in all of us is that we must have breastfed. We must have got the good nutrition in terms of breastfeeding, whether evidence was available at that time or not instead of the formula milks. Our parents must have given us a lot of home-based, culturally acceptable variety of foods instead of the current packets of kurkures and chips and a lot of fast food. We must have played a lot of games like gulli danda, stapu, hide and seek instead of gluing to our gadgets, which nowadays we see. At that time, 30, 40, 50 years back, whether the evidence was there that what was being practiced at that time was right or wrong, I don't know. But what was there, at this point, we know, yes, all those practices were good. So if we think that the most important aspect among us, which differentiates this species Homo sapiens sapiens, is the brain. We have the largest brain as compared to all the mammals. But despite of the largest brain, the human baby is one of the most dependable mammal at the time of birth. So which means when we talk of nutrition, it is not only that we are focusing only on the growth, but simultaneously whatever nutrition we have to give to the newborn, it has to support the brain development, it has to support the metabolism and the immunity. If we look at the American Academy of Pediatrics Committee of Nutrition recommendations that what should be the ideal weight gain, which no one knows. Till now, we don't know what is the ideal weight gain, though we keep on reiterating that yes, whatever the fetal accretion was happening, the same thing, the same centile we should try to gain. But simultaneously, we also need to understand that we just don't focus only on the anthropometric parameters. The composition of the body has to be maintained to prevent long-term metabolic diseases in terms of cardiovascular and all kind of metabolic diseases. Also, we do not want the faltering growth, which has a direct bearing on the brain. So that's the kind of implication when we talk of nutrition and its challenges. Another key concept which we need to understand that for our body, there is only one food our body needs, one kind of food. That is what we just had 10 minutes back, in one way or the other. But our brain needs two kind of. One is the same nutrition which we are talking of, and the second is this, that adequate stimulation and prevention of excessive stimulation. The babies who are being managed by us in our ICUs constantly, like the lights are on, the alarms are on, which gives so much stimulus, and everyone is coming, touching, which is giving so much stimulus. So we have to prevent that kind of stimulus, and where the stimulus is required, that kind of stimulus has to be given. So for the proper development of the brain, it is not only the nutrition, but though this is not a part of the today's talk, but then this is equally important. This is the second food which is required for the brain for the holistic development to achieve the intact survival. All of us know that milk is species specific. But even if you take, let's say, 228 mothers with 28 weaker babies, and if you try to have on the same postnatal age, the milk which is expressed, do you think that the milk will be same in these two mothers? What is your take? Will it be same or different? Same or different? It will be different. Milk has been considered as a personalized medicine. The milk of two mothers cannot be same, then what to talk of the species. If you see that the milk, human milk is designed that in just first 2 years, this is basically supporting the brain growth, and we are able to reach 75% of the adult brain size, unlike the height and weight, which takes time. Whereas if you see the cow's milk, which contains almost 3 times the protein, and this is basically to bring the somatic growth of this baby. So when we counsel the parents that this formula milk, the dabbe ka doodh which you are giving to your baby, this is not meant for your baby. That milk was meant for the cow's own baby, the calf, but not for the humans. But we are using it, and then what we want, the brain of our babies, do we want like this, or we want like our Homo sapiens sapiens? So coming to the first question, from evidence perspective, that what is the best milk, I think there is no debate. Whatever evidence I have written, this is just for the sake of formality. I think it may happen that 50 years down the line, 10 years back, no one was aware of human milk oligosaccharides. Now we know that there are so many 200 plus HMOs. After 50 years, you'll find that there is so much literature which has come up on the composition of the breast milk. It will keep on adding and adding and adding, and we can keep on writing articles and articles on that. But the broad philosophy says that this is not going to change. The breast milk will always and always remain the best, irrespective of any kind of thing which comes up. This is just to show that if you compare the formula milk with its own milk, the risk of infections and NEC is less, and probably it is also helping the cognition. If you compare formula versus donor human milk, of course the donor human milk will be better. And if you compare the term versus preterm for very low birth weight infants, of course the preterm formula, considering its composition and the need of the baby, the preterm formula will be much better as compared to the term formula. So needless to highlight this fact, which has been highlighted earlier, that the best is the mother's own milk. It's followed by the donor human milk, whether it is pasteurized or unpasteurized. And if both these options are not available, only then one resort to the formula milk. But of course, we need to see that why this is not come. I have not written the animal milk, which comes inferior to this, in the fact that formula milk is always better than the available animal milk which we use. And to support this, we need the centers where comprehensive lactation management centers are there. We have enough discussion from Dr. Shushma ma'am. She highlighted the role of CLMCs. But as she rightly pointed out, that when we talk of CLMCs, it is not to produce milk. One of the biggest apprehensions with upcoming CLMCs is that the support to the breastfeeding is going down. It is the focus is only on donation, and donation which should not happen. And see this lactation support which should happen, it is very, very important. Here you can see that the counselors are counseling the mother. And what you can see here, this is the television and this is the pic of the mother. We need to make sure that mothers understand that the milk doesn't comes from the breast. The milk is not found in the breast, the milk is found in the brain. That we have to push. Because once the mother is psychologically calm, relaxed, stress-free, only then the milk will come. Breast is just the source of that. So this is to calm the mother so that she keeps on listening soft music. She sees the face of the baby or her own baby, which makes her to relax to produce more and more milk, and it needs a lot of support. All of us are aware, but sometimes when we see, it looks like that this art of breastfeeding is dying in 21st century. Breastfeeding gives you lifelong returns. Apart from the complete nutrition, a lot of infections, we know diarrhea, pneumonia, they are less. In medium term, when we talk of all kind of allergic diseases are less. In today's era in society, what are the two diseases which we are dealing with? What are the two common diseases in the society nowadays? Hypertension and diabetes. And this simple intervention, which is going to give you benefit after 30 years, 40 years, you are able to prevent right from the beginning. It is an investment in the child. It is an investment in the family. It is an investment in the country. But despite of so much evidence, advantages, still we are lacking behind. And someone rightly pointed out that if breastfeeding did not already exist, someone who invented today would have deserved the dual Nobel Prize, both in medicine and economics. The kind of money saving which we can have from by preventing the purchase of formula milks. Sometimes I wonder, we keep on having conferences, workshops on breastfeeding. But look at this, who is educating them? This was a normal phenomena which was happening. But unfortunately, we lost that tradition, that knowledge was not passed in a scientific manner. We lost that baton, and this is resulting in the use of sort of formula milks. So having said that, so till now we have discussed that the best milk is the mother's own milk. There is no confusion. Whatever evidence keeps on coming in future also, there is no shortcut to that. Now coming to the recent recommendations of European Society of Pediatric Gastroenterology, Hepatology and Nutrition, I just want to bring your attention onto these three things. The fluid intake routinely, these recommendations are basically for babies who are less than 1800 grams and who are stable babies. So the usual fluid requirement, these are 2010 recommendations which have been revised in 2022, got published in 23. In a formal way, they were online, it was available in 22. So usually most of the babies we are able to manage with fluid requirement of 160 to 180 ml per kg, but yes, maximum may go up in given cases to 200 ml per kg per day. The energy requirement is slightly higher based on some factorial designs and the calculations. And you can see that in some babies, sometimes you may need to go as high as 160 kilocalories per kg per day when there is a growth faltering or for the rapid catch-up growth for a short period. The protein requirement, which was initially 3.5 to 4.5, is almost same 3.5 to 4. But when in some, if the growth is not proper or inadequate, sometimes then we may go for short period to as high as 4.5 grams per kg per day. We'll discuss about sodium that now there is an upcoming role of routine sodium supplementation, which may go as high as 6 to 8 milligrams per kg per day. And of course, the iron recommendations by and large same. But yes, there is some evidence that yes, sometimes when the ferritin levels are low, especially when they are less than 35 microgram per liter, in those cases, one may go up to as high as 6 milligram per kg per day, but that is for on a short duration. Routinely, we should not cross this limit of 2 to 3, rather it may create more issues. Similarly, vitamin D, there is just a change of words. Initially, it was 800 to 1000, but now they are just saying 400 to 700 international units per kg. Again, based on some evidence, we're not going to all those things, but with a maximum limit of 1000. So let's look at this case scenario. We have a 29-weeker baby, 1050 grammer AFD, boy born to a 26-year-old primary gravida mother because of preterm delivery. Baby established breathing immediately after birth, was shifted to NICU. There was no malformations. He developed respiratory distress with downies of 4, started on CPAP 5 and 30%. So apart from the primary management of this respiratory distress, with whatever differentials you want to keep in form of pneumonias, RDS, TTMs, what will be your next action regarding the nutrition? What do you think? We have 4 options. I have not made it like a PJ entrance. Now it is converted into the INI exam. So option A is start 10% dextrose. Option B is start 10% dextrose with profit feeds of 15 to 20 ml per kg per day. Option C is start 10% dextrose with feeds of 30 to 35 ml per kg per day, or start full feeds at 80 ml per kg per day. So option A, how many are? So please raise your hands for option A. Okay. Option B. Okay. Option C. Option D. Okay. So I think we'll come back to this question. Interesting to see the kind of responses which are there. So the first question is that, do we need to keep NPO these babies or can we start feeds early? If you see neonatology, in fact, to me, it looks like that in all branches, when we talk of extremes, extremes are always bad. There has to be a balanced path. We talked of 100% resuscitation with 100% oxygen, and then we came to the conclusion, no, it is not right. 10 years back, all babies less than 28 weeks used to get ibuprofen for the treatment of PDAs. But then people started realizing, no, this is not the right approach. We need to find that target population. 15 years back, all less than 28 week babies used to get intubated in the labor room, but then people found out there is a role of delivery room CPAP, 50% intubation. The same is happening here. If you see this meta-analysis, if you start feeds early, in a lot of these trials, we have 10 trials which are enrolling very low birth weight infants, and the feeds were started in 24 hours and some 48 to 72 hours. It clearly shows that the risk of mortality decreases by almost 31%. And of course, it decreases the length of hospital stay. And there is no effect of NEC. Our biggest apprehension is that when we talk of feeds, the thing which comes in our mind is NEC, NEC, and NEC. But data is contradictory. In fact, if you start feeds, we are able to decrease the mortality. So the message is that please start feeds in very low birth weight infants right from the first day. If there is no contraindication. Contraindication means that there is no GI malformations, the surgical conditions. Second, relative contraindications in terms of antenatal Doppler abnormalities, absent or reversed diastolic flows, or the baby is in shock, there is shear parenteral asphyxias. If those relative and absolute contraindications are not there, please start feeding these babies immediately as early as possible after birth. Now the question is that then what is the role of trophic feeds or minimal enteral nutrition? All of us know that The word trophic here means that it is just to prime the gut. It doesn't provide nutrition. The aim is not to provide nutrition. And there are various definitions, but usually 10 to 25 ml per kg per day is the usual volume. And it helps in reaching towards the full enteral feeds where again, there is no increased risk of NEC. All these conditions which have been mentioned, like asphyxias, distress, sepsis, improving shock, ventilations, lines, they are not contraindications for trophic feeds. In fact, these are the indications where trophic feeds are given. So start trophic feeds as early as possible in all infants, preferably with human milk. Where full feeds cannot be started with caution, but with a caution in UW and proper economics. So which means where you are not able to increment the feeds, please continue these babies on trophic feeds. Now, this study is from ma'am, who is sitting here. The role of, I'm sure that this must have been discussed yesterday also. Unfortunately, I was not there. So the first thing we discussed is that yes, in all very low birth weight babies, feed has to be started if there is no contraindication. So there is no question of keeping them in. The second thing we discussed is that if we have to start feeds, what is the volume? Or can we start full enteral feeds on day one itself? Full enteral feed means that we are talking only of the milk. There is no IV fluid altogether in form of 10% dextrose or total parenteral nutrition. So this study was conducted in Kalavati among very low birth weight babies. If you see, these are all stable babies between 1,000 to 1,500 grams. We have almost 90 babies in each. And if you see the postnatal age, which was the primary outcome, that the time to reach full feeds was almost 7 days and 10 days, with a difference of almost 3.5 days. The babies who are on full enteral feeds, they reached earlier, which makes sense. But the apprehensions in terms of the NEC or feed intolerance was not there. In fact, if you see, the feed intolerance is almost 50% less in this intervention group, and the sepsis rate is also almost 50% less, which are both significant. Though the culture positive sepsis is not significant, but you can see the incidence is almost half in the intervention group. Moreover, the duration of hospital stay is less. So which means that instead of our apprehensions, the start of full enteral feeds is rather much more beneficial. After this study, there is a systematic review which has enrolled 4 trials, almost 400 babies, again the same. And the results of this systematic review is almost in the same lines, that there is no increased risk of NECs or feed intolerance, rather the risk of sepsis and the duration of hospital stay is less. But the only drawback is that we don't have a subgroup analysis where we can compare the babies between 1,000 to 1,200 gram or 1,000 to 1,250. Because above 1,250, we are very much comfortable in starting full enteral feeds. So, what we can follow is that if there are no contraindications in terms of absolute or relative, in terms of antenatal Doppler changes, then in less than 1,250 and less than 30 weeker, one may choose to start with TPN. TPNs usually we start in extremely low birth weight, 1,000 to 1,250 grams. Most of the units are comfortable in starting 30 to 35 ml per kg per day with feeds, and by day 2, these babies are on full feeds, except babies who are and less than 1,000 grammer babies, we start with almost 20 ml per kg per day and keep on increasing. But above 1,250 grammers, and if there are no other contraindications, please start them on full feeds. Now, once we have taken a decision to start feeds, then the next question is that how rapidly we can advance. Babies who are less than 1 kg or babies 1,000 to 1,250 grammers, if you have not chosen to start full enteral feeds upfront because of the apprehensions, or you are starting with 30-35 ml per kg, then what is the rate? So this is the latest multicentric European trial where they have taken babies less than 1,500 grammers, almost 2,800 babies. In the control group, they have given 18 ml per kg per day increment as compared to 30 ml per kg per day increment. And their primary outcome was survival without moderate to severe neurodevelopmental disability at 2 years of age. And if you see that almost the survival without moderate to severe disability at 2 years is almost same. There's hardly any difference. The difference is not significant, which reiterates that yes, you can easily go up to 30 ml per kg per day of increment in this population. If we look at the systematic review, the fast increment didn't lead to increase in the risk of NECs, feed intolerance, or mortality, which are our apprehensions. Rather, the faster increment of 30 to 40 ml per kg per day decreased the time to regain birth weight, decrease the hospital stay, and tend towards less sepsis. If we focus from the same review, if we focus on this subgroup that is extremely low birth weight babies, again, the data is very much reassuring that the risk of NEC and mortality was not different if we are increasing by 30 to 35 ml per kg per day. So what we can practice is that in stable preterm infants with no signs of feed intolerance, above 1,000 grams, one can easily escalate by 30 to 40 ml per kg per day, and less than 1,000, we may go up to easily 30 ml per kg per day of increment. Now, coming to this question that should I give the feeds intermittently or continuous? If you see fetus, in fetus, what is happening? Fetus is getting the TPN in the best or the most perfect in terms the way the fetus is getting nutrition. And when the baby is born, we are giving some scheduled kind of feeding 2 hourly, 3 hour, isn't it? So should we give continuous feed for some time and then switch over to the intermittent feeding, or should we directly shift to the intermittent feeding? The evidence says that if you go for continuous feeding, then the time to reach full enteral feeds is longer. The milk which is there in the milk, the fat which is there in the milk, it may adhere to the tube, although the evidence-wise the growth parameters were not different. So considering this, it seems that probably the continuous feed is not a good choice. One should go for the intermittent bolus feeding. And moreover, for the continuous feeding, we need to have facilities for syringe pumps, and it involves constant supervision, which is again difficult in the resource limited settings. Considering all this, the evidence is in favor that one should go for bolus feeding rather than the continuous feeding. But as I said, that sometimes the evidence keeps on changing. So it may happen that the babies, especially who are micropreemies, where we find a lot of feed intolerance, it may happen that in the initial few days, probably the continuous may perform better, though the evidence doesn't support this. And we have just given one DM thesis on the same topic that till first 60 to 70 ml per kg, once the baby is less than 1 kg baby reaches, should we go for continuous feeds or intermittent feeds? So, but overall, if you see, the evidence favors that one should go for the intermittent or the bolus feedings rather than continuous feeding. Another question is that should we go for the responsive feeding or should we go for the scheduled feeding? Responsive feeding means based on the cues. Imagine yourself. Do you want to have a meals at a regular interval, or when you feel that, okay, you are feeling hungry, which usually happens after 4 to 5 hours of any intake? So what do you think? This is better or this is better? What is your gut feeling? Before we go to the evidence, what do you think? Responsive feeding is better or scheduled feeding is better? It looks like that probably the responsive feeding should perform better, isn't it? When I am feeling hungry, I would like to take, rather than that someone is just giving me and I am galloping after 4 hours or 5 hours. But if we see the responsive feeding, the benefit is in form of that it decreases the length of hospital stay. But the harm is that if you see the weight gain velocity, it was less. And but the quality of evidence is again very low in both the sides. And again, for responsive feeding, the issue is that someone has to be there, the staff or someone or the mother, who is actually noting down that yes, this my baby is looking at giving those cues. First is that kind of sensitization has to be there. When I joined MD, I used to think that the newborn communicate only in one way, and that was crying. But I was wrong. Gradually, I learned that there are so many cues which we don't understand. Probably at this stage also we don't understand. So looking physiologically, it looks like yes, responsive feeding should perform better, but the evidence is not favoring that, and we need extra resources. So considering that, as of now, scheduled feeding is considered for the preterm babies who are hospitalized and who are less than 34 weeks until discharge. Of course, after discharge, when they are above these gestations, of course, the mothers usually go for so-called semi-demand feeding. It is not a scheduled feeding, it is not a responsive feeding, it's sort of a semi-demand feeding. Now, when we're talking of scheduled feeding is better in the hospitalized babies as compared to responsive feeding, then what should be my feeding interval? Should I go for 2 hourly feeds or should I go for 3 hourly feeds? If we see the 3 hourly feeding schedules, again, the 3 hourly feeding schedules have not resulted in any kind of adverse events. Rather, it has saved nursing time and the birth weight regain is faster. But if we see all these studies, the extremely low birth weight babies were very less, and rather whatever the limited data is there, the time to reach full feeds was higher in ELW population. So considering that, we can say that babies who are more than 1250 grammar, you can easily give 3 early feeds. Babies who are less than 1250 grammars, till now, with whatever evidence is available, we can go for 2 early feeds. But remember that when you implement this in your unit, you have a heterogeneous population. You have some babies less than 1250, some more than 1250, and it should not happen that out of this confusion that actually the baby has not received feed at all. So whatever you want to follow, because like in our unit, despite of this evidence, we are giving 2 early feeds to all the babies. We are following scheduled feeding, not the responsive feeding, and 2 early because of this apprehension. That it should not happen that out of this 2 early and 3 early, some babies have got closed. So evidence is there. You think in your context what is better. If you can implement that, means it's up to you. Now, I think yesterday we also had a discussion on the fortification. And there is no confusion that for very low birth weight babies, the fortification is required. The reason is very simple. If you see what is the ideal energy to protein ratio, that is 2.8 to 3.6 gram of proteins per 100 kilocalories. And you talk of look at any human milk or any kind of this is very difficult to achieve. Very difficult to achieve this ratio. Even if you add fortifiers, we are hardly touching almost like 2.5, 2.4 to 2.6 grams per 100 kilocalories. And in this graph, you can see if you are giving energy intake is normal or high, protein intake is normal or high. This is the area where we want normal energy, normal protein for the best fat-free mass. Because the goal of nutrition is not only for the anthropometry, but also to maintain the composition. So there is no denial, fortification is required, and it has shown that at least the anthropometric parameters in the hospital are better with this, though we don't have any advantage in the long run. So please use HMF if the babies are on mother's own milk or donor milk for all less than 15 milligram babies. So one should go for multi-component fortifier. Now again, it's a debatable issue that what is the ideal time of HMF. When I did MD in 2005, 2006, at that time we used to start HMF at 150 ml per kg per day. But after that, some evidence has come up which has shown that yes, early fortification is safe, and there is though early fortification has not resulted in any difference in the growth rate. We assume that okay, if you are starting early, then probably the growth rate will be better, but it is not so. But it has been shown that there is probably the overall deficiencies is less. So the current recommendation says that one can add HMF once we are at a volume of almost 40 to 100 ml per kg per day. You can see that there is a wide range because this is based on 3 trials which have used different. Some have started right from the day one, some when the babies are at around 40 ml per kg per day. So because of this limited evidence, there is a wide range. But again, whatever you want to follow in the evidence, remember one very basic thing, not only for nutrition, for all interventions, whatever you are practicing, you are changing your practice, please keep on recording your data, because that is going to tell you whether your practice, whatever you are implementing in your system, is right or wrong. What about adjustable and targeted fortifications? Adjustable when we are increasing the content of the HMF based on the blood urea nitrogen, and targeted which we are measuring and then adding, which is not practically possible in our setups. We don't have milk analyzers and we don't have that kind of fortifier. So this option is out. There is some role that yes, probably adjusted fortification one can do, but we are not practicing it in our unit. There is some evidence that probably it may lead to some better growth. Another common question, I think most, what you are practicing, are you people putting orogastric tubes or nasogastric tubes? So I think virtually most of us are putting orogastric, though if you again talk of evidence, as I said, that evidence is something you can tweak on this or that side based on your own thing. So, though physiologically, yes, there is some data which says that probably the nasogastric tubes leads to increased AV resistance. The nares are already small and you are further increasing the resistance and work of breathing, but it is not leading to increase in desaturations. So, so probably if you look at the evidence, it says that you can use any of these options, but yes, most of us are comfortable in using orogastric tubes. Coming to the other issues, that is NNS, which is again a part of developmental supportive care also, which is a very important interventions. See, this simple intervention is reducing the time to reach full feeds, improving the breastfeeding rates at discharge in the hospital stay. Problem is that when something where money is not involved, we think that that intervention is of no use, but those interventions are very good. KMC, the NNS, these are very simple interventions, all developmental supportive care. What about transition from gavage to spoon feeds? One can start, give a trial somewhere at around 31 to 32 weeks of postmenstrual age, but of course, it has to be individualized. There is nothing like that, okay, over 3 days, 5 days, 10 days. You need to see, because it all depends on how much the baby was sick, what kind of parental insult has happened to that baby. So when we are transitioning, do I have something to improve the oral feeding skills? Because all these babies, they had feeding tubes for a longer time. They were having ET tubes. No one has given that kind of stimulation. If I ask you, आप में से कितनों ने गन्ना चूसा है? ई से ईख, sugar cane. Chalo, good. At least 50% of you. So those who have not ever tried that, if you tried for the first time, it will be difficult for you. In fact, people used to say that previously we used to chew those chanas, all these raw vegetables, the carrots, radish. It helps in molding your this whole jaw. Imagine a baby who has been in NICU for such a long time with a feeding tube, ET tube, no kind of stimulation has been given, and then suddenly the 31 weeks has reached and the baby is now in HFNCs, and we start thinking that, okay, let me start trying spoon feeding this baby, and the baby doesn't take. There is a proper, the suck is not proper, the swallowing coordination is not coming up. So what can I do? This is premature infant oromotor intervention, the POMI tool. We have just introduced in our unit 2 months back, and you believe me, the results are wonderful. Wonderful results. This is a set of exercise which common sense says that you have to just stimulate this area the way the baby takes. You have to different all the cheeks, the lips, the gums, the tongue, all these areas needs to be stimulated. You can go to the YouTube, the time is not there to run the videos, and you can see. It is very simple to do. And it has been clearly shown that by this, the babies are able to transition to the full oral feeds early. The length of hospital stay decreases and the time spent on the parental nutrition decreases. And this is just to show that this is like cheek stretching, the lip roll, the lip curling inside, and then you have gum massage, and there we have the tongue. And so basically we are stimulating this area, and this is a simple tool which you can learn easily, and then you can teach your nursing officers, and this is going to help a lot. Otherwise, a lot of our babies are stuck up, and the staff will say कि sir हमने तो इसको spoon feed try किया था, बच्चे ने choke कर गया, बच्चे ने cough कर दिया, बच्चा desaturate कर गया, and then we are lingering, and we are waiting कि one day will come, we'll again give a trial. They believe that okay, this day will be the perfect day. So I think instead of relying too much on the God, we should rely more on POMI rather than God. So the biggest apprehension while increasing feeds, while giving feeds, is this necrotizing enterocollitis, and which always takes us at the back. Now let us see this. A lot of signs and symptoms which are related to the feed intolerance. If we see vomiting, the gastroesophageal sphincter tone is less, which is causing reflux, which is sometimes interpreted as vomiting, taken as a sign of feed intolerance. We know that their gastric emptying time is low, the gastroduodenal hypomotility is low, so which results in gastric residuals. And we interpret that this baby has feed intolerance, and we are at the back foot in increasing the feeds. We know, we have been conventionally taught that if there are green aspirates, it has to be surgical cause, please make NPA. But we should also consider that duodenogastric reflux is a normal phenomena. Sometimes the positions of the tubes are transpyloric, which can also lead to the same. What about blood stain? We used to be taught that even if there is a 0.2 ml of 0.1 ml of altered gastric aspirates, please withhold feeds. But so many times the babies are on CPAP, and sometimes the humidification is not proper, or if someone has done vigorous suctioning, the same kind of blood which is going into your stomach, and if you aspirate, it is going to cause this. What about abdominal distension? The biggest problem with these measuring tapes, and when we look at the abdominal, this kind of variation, 2 to 3 centimeter variation, the point at which you have taken the one staff versus the other staff. And we also know that there is some hypomotility, the babies are on CPAP, which can all. So all these are the physiological bases. I'm not saying that they are not pointing towards feed intolerance. Yes, but then there are some physiological reasons also for the same things. So we don't have enough evidence that what is the best sign. But it has been shown that the routine pre-feed gastric residuals, if we just keep on following that, rather it is more detrimental. It has shown that it delays the time to reach full feeds, and of course the parental nutrition days keeps on increasing. So we should, if you are practicing, then please go with the routine, so-called routine pre-feed aspects. It has to be done only if you are finding some other associated signs of feed intolerance, yes, in that case, it is justified. So you have a huge list, but the bottom line is that there is no consensus with a lot of variations among various units. So while defining feed intolerance, use a combination of all these steps. And if we see the NNF CPG 2022 recommendation, it clearly says that we should not do pre-feed aspirates nor the routine abdominal girth monitoring for the feed intolerance. Yes, if there is one thing, then you can go for the other thing. If there are other systemic symptoms you are thinking, yes, you should do. But that not only that every time we are religiously doing and then withholding feeds because of these issues. Coming to the feeding in special situations, this is a special subgroup where we have antenatal Doppler abnormalities. I'm not going to the detailed protocol, but the bottom line is that babies who are extremely low birth weight and have Doppler changes, this is the population which is at a very high risk of necrotizing. So in these babies, some units keep NPO for 6 to 12 hours, some even keep NPO for 24 hours. Please start trophic feeds once you feel that yes, the bowel sounds are good. Meconium passage is not an essential thing, like in other babies, and closely monitor. So start trophic feeds based on the condition and go slowly. The routine increment which we do, probably 50 to 60% of the increment, especially in first 4 to 5 years. That is there. This is another thing which haunts us, that I am giving packed RBC transfusion. There is an apprehension of transfusion associated necrotizing enterocolitis. Should I continue feed? Should I withhold feeds? Withholding feeds means that you have to start IV fluids and then baby has to again be shifted for that 4 hours, 5 hours, 6 hours duration. So what should be done? If we look at, again, if we go with the evidence that there are 7 observational studies and only 1 RCT, and this RCT has never shown. But these, if you see 7 studies, these studies points that yes, the risk of NEC is high if you continue to feed while giving blood transfusions, and but the quality of evidence is moderate with the weak recommendations. As of now, NNF recommends, the NNF clinical practice guidelines, they suggest that yes, one should withhold feeds 3 hours prior to the end of blood transfusion, and then once the packed RBC transfusion is over, then you can start feeds. But still, you will find that there is a lot of variation among the groups. If you ask me what we are practicing, in the sick babies or the babies who are relatively sick, we do follow this, but once the babies are stable, they are growing and just need transfusion, we don't do. But then again, there is a debate. Recently, I had a discussion with one of the very famous neonatologists. He had a very bad experience. He lost 2 babies because of this, all stable babies. So as I said, that you will find some heterogeneity among us also, that what is being practiced, but the overall evidence, we need more evidence in this direction, and this is an ongoing trial, multi-center trial by the name Dept, with holding enteral feeds around red blood cell transfusions. Probably that may give us some lead that what should be practiced. Now, should I routinely supplement sodium to very low birth weight infants? Still now we have been continuing with 2 to 4 milligrams per kg per day, and once these babies are on full feeds, then usually we don't routinely supplement. But then we know that there is these preterm babies, especially who are less than 30 weeks, the tubular sodium losses is high, and the sodium concentration of the milk also declines after in the first week itself. And when we look at their serum sodium, the serum sodium levels probably reflect more of the hydration rather than the total body sodium. And if you see our 45s, the typical Dexulac or ESPGHAN, if you try to calculate, it hardly gives you around 1.9 milligram per sachet. So even if you are using 10 sachets, so 19 milligram is almost like 1 milliequivalent of sodium. So the overall sodium content is low, though we keep on routinely measuring after 3 weeks for the late onset hyponatremia, and the values are okay, but we don't routinely supplement. But there is some evidence which is coming in this direction, that people have tried comparing 4 milligrams per kg per day routinely by end of first week to 5 weeks with the sterile water, and they have found that the overall incidence of late onset hyponatremia is less, the velocity of the is less, there is improved somatic growth, and there is some evidence that probably it may also help in the neurodevelopment, maybe because of the growth itself rather than the sodium affecting the brain development. So there is some evidence, and the ESPGHAN does recommend that yes, one should go for the sodium supplementation around 3 to 4 milligrams per kg per day in very low birth weight. in infants. And when we are adding sodium supplements, please divide them to maintain the osmolarity so that we don't cross that osmolarity of 450 or 500 milliosmoles per kg. Iron supplementation, we already discussed. We have been giving to all very low birth weight babies at 2 to 3 mg per kg per day at 2 weeks, starting at 2 weeks of age. ESPGHAN says that one can go up to 6 mg per kg per day, which is required if the babies on erythropoietin. Most of us are not using erythropoietin because of various multiple reasons. But if the infant is anemic and we have got the ferritin done and the ferritin is less than 35 microgram per liter, then please don't hesitate in increasing this iron from 3 to as high as 6 mg per kg per day. But having said that, please decrease it after 4 to 6 weeks by the time that replenishment is happened. Another issue which was not addressed in the previous guidelines was that we keep on transfusing. A lot of these babies require blood transfusion, especially the extremely low birth weight. And this blood transfusion also causes a lot of iron overload. So in these babies, should we give iron or not? Though we say that on all very low birth weight, we should start 2 to 3 mg per kg at 2 weeks. On other hand, we are giving so much iron through the blood transfusion. So these guidelines says that if this ferritin levels, in these cases, we should do the ferritin level. If it is more than 300 microgram per liter and not in the absence of inflammation in liver disease, because we know that ferritin is an acute inflammatory marker. In those cases, one should withhold iron and wait till the time the levels decreases below 300 microgram per liter. And then you restart serum iron. It has to continue till 1 year of age. For all low birth weight babies, start at 2 mg per kg per day at 4 weeks of age till 1 year of age. Zinc supplementation, there is now ample evidence, which is in general for the preterm babies, that among preterms, and this population is by and large above very low birth weight, so which is 1.5 to 2.5 kg babies, that it helps in improving the weight gain, decreases diarrhea, and may also decrease the mortality. The A to Z drops, there is no conflict of interest here with any of these companies, but then the A to Z drops, which we have been conventionally using, it doesn't contain any kind of zinc, whereas bisoprolol contains 2.5 milligram. So ESPGHAN recommends that zinc 2 to 3 mg per kg per day should be given in all preterm and low birth weight infants. But the problem here is that what is the ideal time point? If you see the studies, people have started as early as 1 to 2 weeks of age to as high as 5 to 6 weeks of age, and it has been continued from 3 months to 6 months. So that part is not very clear to anyone. So the guidelines are silent on that. But the overall favors that yes, it helps in weight and I will not touch upon all these things because calcium, phosphorus, all of us are aware. Vitamin D, we have already discussed that previously it was 800 to 1000 units. Now they have just converted into international units per kg per day with a maximum of 1000 international units per day. This $1 million question, no one has the answer. That what is it? Sure, just 2 minutes. That what is the ideal weight gain, but then no one knows, but we try to mimic this. And the target is that the weight, which we typically say is that 15 to 20 gram per kg per day of our weight gain, the length and the OFC 0.7 to 1 centimeter per week is our target. I'll skip this because this will be covered in EUGR talk. Another common question which we face in our OPD is that when these babies comes in a follow-up, at what point we should start the complementary food? Should I take chronological age? Should I take corrected age? This trial is from Lancet Global Health from our own country. Dr. Suchita had done this. And there is a recent trial which has been published in Nutrients. If you see the summary of both these trials, they have enrolled less than 34-weeker babies. They randomized into 2 groups. One started at 4 months of corrected age, another at 6 months of corrected age. And the primary outcome was the anthropometry at 1 year. There was no difference. Whereas in Indian trial, they found that babies who were started at 4 months of corrected age, the incidence of hospitalization was more, the infections were more. So as of now, there is no clear-cut consensus, but people tend to favor to delay it as far as the starting point of this adding complementary. All of us know that we have a lot of interventions, but then we fail while we implementing. All of us know that what we had, the good treat from Kirti and her team, but whether it is good or from health perspective, it is good or not. So I think we need to keep on looking at our own data. We need to improve ourselves, and having just a standardized feeding regimen in our unit helps a lot. I would like to focus on these 5 points. This is very important because whatever we keep on doing, but to gain maximum benefits, the maternal nutrition right from the preconception to the antenatal is important. Just focusing on the baby is not going to solve the problem. Focus on glucocorticoids to prevent NECs, practice GC, delayed cord clamping, increase the availability of milk by early expressions, and try to prevent sepsis. So I'll conclude saying that human milk is the best. Of course, it needs fortification for very overweight babies. Trophic feeds, yes, has to be given if we are not able to progress. Use 2 to 3 hourly feeds with orogastric. Use multiple signs and symptoms to assess the feed intolerance. Micronutrients plays an equally important role, and do regular auditing and try to fix the contextual. Thank you so much.